you very much indeed. Yeah, thrombomodulin is also a natural substance. We all have it. It's not really a vitamin, but it is a valuable option in the management of sepsis cases. And in particular, because it targets the microcirculation close to the cells. We all know that in sepsis, there is typically a maldistributive defect with a high cardiac output, a high SVO2, and a lot of things going on in the periphery with vasodilation, with decreased cell deformability, altered glycocalyx, microvascular obstruction, circulating vasoactive substances, endothelial dysfunction. We have seen these images of altered microcirculation under the tongue, for instance, where we can access it relatively easily. But the endothelium could be a target. And this is a very old slide and a very old concept of an interaction between coagulation, inflammation, and organ dysfunction. And indeed, there are many data showing that this interaction can play an important role in septic patients. Thrombomodulin is a natural anticoagulant, so you may think, aha, yeah, okay, they are microthrombi, right? That's what they are targeting. Not so much, because after all, when you look at the sublingual circulation in sepsis, septic shock, you know, when you put some acetylcholine locally, you can reverse these microvascular alterations. So it cannot be microthrombi. Microthrombi would not be affected by acetylcholine, right? So don't try to catch me with that. You may say at autopsy we don't see microthrombi. I agree. It's something which is probably of relative little importance. And yet, the activated platelets together with the activated leukocytes and many other substances can play a role in the alteration of the microvasculature. So there is a lot of interest in anticoagulation in a broad sense. And our Japanese colleagues in particular are really very interested in disseminated intravascular coagulation in sepsis. Now, as we mentioned yesterday, we had one drug in the treatment of sepsis, and that was activated protein C, trotricogaine alpha activated. Activated protein C is a natural anticoagulant, and we could show a significant improvement in survival. We could not believe that, so there was a second study rapidly conducted, which was totally negative, and the drug was taken out of the market. And yet, what is interesting is that we learned a lot about the mode of action of activated protein C, and it's not just an anticoagulant. It works on a number of processes, and of course, I'm not going to discuss them. But when we looked at the microcirculation following the administration of activated protein C, that was more than 10 years ago, we could see a significant improvement in the microcirculation when that drug was administered. The problem was that we could not identify the patients who could really benefit from it. It's the concept of endothelial microvascular support, but what is the marker? We need a marker. We need a phenotype again and again and again. There was one paper which did not have much impact at that time, which indicated that actually in patients with severe coagulopathy, with severe disseminated intravascular coagulation, DIC, there was a more substantial reduction in mortality rates than in the patients not having a severe coagulopathy. So, going back to our three natural anticoagulants, we know that thrombomodulin works together with protein C. They really interact with each other in their natural anticoagulant properties. I mentioned activated protein C as other activities than anticoagulant properties. And that's true for thrombomodulin too. In particular, it can interfere with complement pathways. This has been known for a number of years. And also, there's nasty mediator or cytokine HMGB1. And HMGB1 levels are particularly elevated in patients having a poor outcome. So a Japanese company could develop a recombinant form of thrombomodulin called ART-123. It's composed of soluble and active extracellular domains of thrombomodulin. So in Japan, they evaluated the effects of this recombinant thrombomodulin in an endotoxic shock model with beneficial results. Wow, okay, that's endotoxic shock. Okay. Well, there are some other very nice studies showing that in ischemic kidneys, the administration of thrombomodulin could really protect the kidneys. Very interesting study from Professor Molitoris in the States. Okay. I know. We'd like to go to clinical data. Okay. Well, soluble thrombomodulin levels in the blood are associated with more renal failure, since I just spoke about the kidneys, and also a higher mortality rate. So they are a bad sign. It's a bad sign to have a lot of thrombomodulin soluble thrombomodulin in the blood. Now, our Japanese colleagues did small studies on DIC, but they could show in small numbers of patients that there may be an improvement in outcome with this recombinant form of thrombomodulin. And actually, that was approved in Japan. So it's a drug in Japan. You can order it, you can give it on the basis of very limited data. But it allowed our Japanese colleagues to do retrospective studies, propensity match studies, and this is a study published several years ago with a historical control showing that maybe there is an improvement in survival rates with the administration of thrombomodulin. There is another study with propensity scores. It's a multicentric study showing also a possible reduction in mortality rates. Another study published more recently, propensity score matching, again, the same message. There may be a lower hospital mortality, a longer survival time. Another study here on 2,663 patients, but this was on anticoagulants and including thrombomodulin, and there was again a survival benefit. Now, interestingly, and that's a recurrent theme that we have heard at various sessions during this meeting, yesterday and today, when you look for a difference in mortality rate, you must go to a very severe patient population. So you hope that this will be more effective in patients having a higher risk of death instead of those doing already relatively well. So if you can look at Apache scores, for instance, it works somewhat better in patients with high Apache scores than in patients with low Apache scores. The same thing in another study on propensity score analysis. It works better in very sick patients. And I showed this slide yesterday, indicating that indeed, if your drug works less well in the patients who are about to die, or works better in the most severe cases, regardless of the scenario, you do not want to enroll patients who are going to do well. How can you increase their survival if they are all already surviving and really getting better? It would be ridiculous. With activated protein C, some of you who have known the story will remember that it was particularly effective in patients with high Apache-2 scores, so that in the US in particular, they reserved sometimes the use of the drug to those patients having a high Apache score. So with recombinant human soluble thrombomodulin, it's the same thing. When you look at the risk of death, it seems to work better in patients with a high risk of death. And this has been, again, shown in recent studies. So there is quite a large literature, but these are not prospective randomized controlled trials. These are retrospective analysis of sometimes large databases, not small numbers, but large numbers. Interestingly, the pharmacokinetics do not create much problem. So in patients who are in renal failure, even with renal replacement therapy, it's not really a big issue. So going back to what I said yesterday, we need to have better defined patient populations for our trials. And of course, for a new drug, even if it's a natural substance, we need a prospective, randomized, controlled trial. No doubt about this. In the future, we'll no longer speak about sepsis drugs, but now we are focusing on a particular phenotype associated with disseminated intravascular coagulation. That's what I like. We could have the biomarker that suggests that there is something going on in the microcirculation affecting the coagulation there. And that's how in a phase 2 study, we reported that in these patients, there appeared to be a subgroup of patients with low platelet count and prolonged PT who seemed to benefit. Very simple, platelet count PT, we all measure it without any difficulty in our institution. And that's how we conducted this 800-patient study, whose results were published recently. And it was really sepsis with either shock or pulmonary failure, but it was primarily shock in the vast majority of cases. And the primary site of infection, interestingly, was intra-abdominal, whereas in our studies on sepsis, we usually find pneumonia at the top of the list. However, when we look at data on DIC, and this is a paper we published several years ago already, coagulopathy is more common in patients with sepsis with an abdominal source than in patients with a respiratory source of sepsis. So after all, it's not so surprising that we had a substantial proportion of patients with sepsis coming from an abdominal origin. Now, the global mortality was not significantly different, although there is a little bit of a difference. It's 2.6 difference going in the right direction, 26.8 versus 29.4. But okay, once again, not sufficient to have a drug on the market. Now, what we did is to look at the patients who really had the coagulopathy at time of administration of the first dose of thrombomodulin. As you can imagine, you look at the inclusion-exclusion criteria. Okay, the patient can go in the study We continue to treat the patient as we go to have the informed consent. We prepare everything, and sometimes patients no longer met these criteria, but they were in the study, they received the drug. So at the right side, you can see that the signal is greater in patients who had the full DIC criteria when the drug was first administered. And now we are looking at a 5.4% absolute reduction in mortality rate. It's not bad. It's a subgroup analysis, okay. But it reinforces the fact that we have a signal. And this was not at the very end of the study. The signal was there throughout the study. Very interesting. So we may be on the right track. We looked at various coagulation variables, and this paper is submitted now. But it seems that indeed there is a nice correlation between the degree of coagulopathy and the clinical response. Hopefully, thrombomodulin is very safe. We looked, of course, as you can imagine, at major bleeding events in particular, and there is really no concern whatsoever. So we have a signal. There seems to be something there, but not enough to have a drug on the market now. And at the end, I'd like to go back to what we said yesterday. Sepsis drugs are over. Sepsis drugs are over. This era is over. I think we are now considering phenotypes, coagulopathy and endotheliopathy. And to illustrate this, I'd like to go back to an old study published more than 10 years ago, but it really interested me, which shows that when you look at sepsis in red or organ failure without sepsis in orange, you can see the same degree of coagulopathy. So maybe if we can go on in that direction and if we can have the product available, it could become available for organ failure with DIC, coagulopathy, as the Japanese colleagues wanted from the beginning. So we could even have an alarm signal from the lab saying, we have the combination of a low platelet count and a prolonged PT here. Look, is it something acute? Is it something which is not related to cirrhosis or anything like that? But, pay attention. And we may actually say, yeah, that may be a patient with organ failure, an acute problem, who may benefit from this therapy. So I think this audience is convinced that there is an urgent need for new sepsis or ICU drugs or organ failure drugs. The importance of coagulopathy is clearly there. Endothelium is a valuable target, and the wide availability of simple blood tests can be very attractive to identify the suitable patient population. Of course, all of this is work in progress. I'm not trying to convince you that this works and we should use it tomorrow. I think we are on the right track. It emphasizes phenotypes, better recognition of the patient populations for our interventions. Thank you very much.
Thank you, Jean-Louis. Any question? I have one, which is the interaction with heparin, because some of the other anticoagulants have and seems to impact in the effectivity of the compound.
Yeah, very good question. And indeed, a post-hoc analysis revealed that patients who were not on heparin appeared to benefit more from thrombomodulin than the other patients. So now we are exploring the possibility to invite the investigators for the next study to avoid giving heparin in the acute phase of septic shock, basically. I don't think that it will raise many problems, especially ethically, as there is no definitive indication for heparin in the acute phase of septic shock. But yes, there is a possible interaction that we need to further explore. The problem is that if we exclude more patients, the enrollment rate may become really problematic. And you know, it took us already several years to have the 800 patients in the trial. And nobody wants a trial that will last 6 or 7 years. We would like to have it over a relatively reasonable period of time. So there is a compromise between patient selection and duration of the study.
Thank you very much, Jean-Louis. We have no time for further questions.